Yes, ma'am, we are live now. You can start.
Some
Good
problem.
evening, doctors. Thank you very much for joining today's webinar. I am Dr.
Welcome,
Prachi
Jyoti
from
Dean.
Shield Healthcare, and I welcome you all. Today's webinar is brought to you by AMOG's Medical Disorders Committee, and I'm very happy to introduce and privileged to introduce the convener of today's webinar, Dr. Shashibala Bhosle Sao. Ma'am is immediate past president, Gwalior OBGY Society 2023, National Coordinator, IAEC Committee, FOXY, consultant gynecologist in Public Health and Family Welfare Department of MP Government. Our coordinator is Dr. Prajbala Tiwari. Ma'am is president, Indore OBGY Society, vice president, Indian Medical Association, Indore and Indore Menopause Chapter. Secretary ISOPOP chapter Indore and joint secretary MP ISA till 2024. Ma'am has organized many surgical workshops and was guest speaker in national and international conferences and the recipient of many awards. So I welcome you, ma'am. Thank you very much. And our next coordinator is Dr. Jyoti Banglowala. Ma'am is vice president Indore OBGY Society. Also executive member in Practical Ops Committee till present. Recipient of many awards, including prestigious Wonder Oxygen Award and IMA Corona Warrior Award by MP Government. Published many papers and was guest lecturer in many conferences. So with this, I hand over today's session to Dr. Shashibala Bhosle Sao. Thank you very much.
Thank you. A warm welcome to all the, it seems like a guest full of stars. So this evening is going to be really, really starry. And we are lucky. We have legions with us. Dr. Pardesi sir is there with us. Thank you, sir, for gracing the occasion. And Dr. Jyoti Bindal, in spite of her issue, she is with us. And Dr. Sneha, when she said she wants to do a webinar with Gwalior, MPOX cream is here. All the three Bs. Asha Bakshi ma'am, namaste. Kavita, our favorite, our superstar, our hamari pehchan in Foxy. She's the pehchan of MP, and she only took us to Foxy. And Dr. Archana Basir ma'am, and we had going to have a good sessions with dynamic speakers. Dr. Kavita, by the way, it's a real charm to listen to her. So without wasting any time, first I would like, before we start anything, can we have lamp lighting, please? Before I ask Dr. Sneha for her welcome address. Thank you. Hello.
Yes, ma'am.
Thank you. Yeah, thank you so much. Now, I have the privilege of introducing our so dedicated Sneha Buyar ma'am. She has really taught us how to be dedicated, and I have the opportunity of introducing her. Can I have her CV, please? A proper introduction of all these years. And Dr. Sneha Buyar ma'am of all, very best for her on forthcoming elections as Vice President VP for Foxy. And her CV cannot be in 4 lines. She has been Foxy Breast Committee Chairperson 19 to 21. Gwalior has been lucky. So many Gwalior people were there with her. GCM ICOG 21-22. MOGS MD Chair 22-24. Right now she's doing that. And CEFOG Working Group Member, Founder President with ISOPUB. She has won International
Thank you.
MS Signature Award for Phenomenal Leadership in 2020 and Asia's GCC Award, SN Malhotra Award, Durusha Award, Anandibai Joshi Award. So many and so much to speak about her. Over to Sneha. I will not.
Thank you, my dear. Thank you so much. A very good evening and a warm welcome to respected Dr. Rajendra Singh Pardesi and Madam Sujata Darvi. Sir is the AMOG's President and Madam AMOG's Secretary. Today's chief guest for this program, Madam Jyoti Bindal, such an illustrious person. I welcome you, Madam, and guest of honor are 3 Bs, Dr. Asha Bakshi, Madam, Dr. Archana Basir, Madam, and Dr. Kavita Bapat, Madam. And of course, my dear friends, Dr. Braj and Dr. Jyoti as the coordinators, and of course, Shashibala as conveners. I welcome all the speakers, Dr. Anupama Dave and Madam Kavita Singh, and of course, all the chairpersons also, Dr. Madhuri Chandra, Dr. Vrunda Joshi, Dr. Anita Srivastav, Dr. Manik Panse, Dr. Jagruti Nagar, Dr. Sunita Wadhwani, and our panelists who has, been very enthusiastic to participate in the panel discussion. We have Dr. Jyoti Karande, Dr. Shabana Sultan, Dr. Dipti Gupta, Dr. Aditi Rathod, Dr. Shruti Malvi, the young talent, and of course, we have so many other viewers here. So at the outset, I would like to thank AMPOX for giving me this opportunity. I would like to welcome all of you. And of course, I would like to share with you that this platform, which we are going to discuss here, the medical disorders of pregnancy, especially hypertensive disorders in particular, and of course, the critical care cases also we're going to discuss here. So this is going to be a very useful learning for the day-to-day practicing obstetricians. And I wish all the best for this program. And of course, I wish all the best to the contestants, Dr. Kavita Bapat, Dr. Jyoti Banglowala, and Dr. Prajbala Tiwari. And with this, I thank all of you and for your gracious presence. And of course, I invite my mentor, the past Vice President of Foxy and the past Committee Chairperson of Food and Drug Committee, Dr. Rajendra Singh Pardesi, who has actually handhold and taught me how to go ahead in Foxy. And we are very eager to listen to you, sir, and have your blessings. Over to you, sir. So please unmute, sir.
Good afternoon, everybody. Respected chief guest, Dr. Jyoti Bindal ma'am, and guest of honors, our 3 sisters from Indore, Dr. Archana Basir, Dr. Asha Bakshi, and Dr. Kavita ma'am. Our AMOG secretary, Dr. Sujata Dalvi, Dr. Kiran Kurtakoti, Dr. Lakshmi Sekande, Dr. Ashok Kumar, and our ever active, ever smiling chairperson, Dr. Sneha Bhoyar, and conveners, Dr. Shashibala Bhosle, Brijbala Tiwari, and Jyoti Banglowala. I congratulate Dr. Sneha Bhoyar, Dr. Shashibala, Dr. Brijbala Tiwari, Dr. Jyoti Banglowala for organizing this event jointly together, that is AMOGs with MP societies for women's health. And this webinar on obstetric topics that are very useful in day-to-day practice and will definitely reduce maternal mortality rate. I wish every success to Dr. Kavita Bapat ma'am for her future endeavor in Foxy as President Foxy, Dr. Sneha Bhoyar for her future endeavor as Vice President Foxy, and Dr. Shashibala Bhosle, Dr. Brijbala Tiwari, Dr. Jyoti Banglowala for chairpersons wishing every success to this webinar. Thank you. Thank you so much for inviting me.
Thank you so much, sir, for your precious words and blessings for all of us. We have been blessed by your presence. And now, Madam Sujata Darvesh is busy in the Yatra and she's in the South India right now. So she has conveyed her apologies, but maybe if she can join later, we will have her blessings. So now I invite our chief guest for today's program, Madam Jyoti Bindal, who has always been so inspiring to all of us, such an illustrious personality with a highly decorated CV. And Madam, you are really an inspiration for all of us. Madam has been the Vice Chancellor of Sir Aurobindo University, Indore, and of course, she has received the National Academy of Medical Sciences Award, what is J.G. Jolie Oration Award, and she has been the President of Association of Madhya Pradesh of Gynae, strategic advisor of member executive committee of BT and UK, and Madam has so many accolades and credentials to her credit. So we would like to have your inspiring words, Madam. Over to you.
Thank you so much, Sneha. And once again, I feel very honored and privileged to be invited by you. And as I always tell you, I can never say no to you. I'm really honored to share the platform with Dr. Pardesi, Dr. Asha Bakshi, and of course, let me phrase it and say our incoming president, Kavita Bapat. And Kavita, trust me, my words always become true. So incoming President Kavita Bapat, incoming Vice President Sneha, and incoming committee chairpersons Brijbala and Jyoti. And am I missing somebody? No, that's it, right? I think obstetric close calls is such a wonderful topic because in these days, all the webinars are literally packed with ovarian reserve, infertility, medical management of FUBs, those kind of things. So as we know that most of the general practitioners in our country, even today, practice a large bit of their practice is obstetrics. And the topics which you've chosen are really something very close to heart. We have another incoming president of MPOX, Dr. Kavita Singh, today speaking on peripartum cesarean hysterectomy. And trust me, those of us who have worked in medical college hospitals know that this is a very startling truth even today. So many cases have to be converted into a case of hysterectomy. They always come with either rupture uterus or something like that. Many of the private practitioners even today refer such cases to the medical college hospitals. And so I would very strongly claim that we have seen probably the largest numbers of these cases. And I'm sure Kavita being HOD in Jabalpur and the people who are chairing her, again, very close friend of mine, Vranda, who's now chairing Department of OBGYN in Gwalior, and Madhuri Chandra, again, who's remained for so many years in Bhopal Medical College. So 100%, these are the people who have come across these cases so often, and probably a very right team of choice, Sneha, for this. Again, the second topic, obstructed labor. Even today, once again, I'm saying obstructed labor is something which a lot of peripheral hospitals today see, and then after having tried every possible drug and every possible method, they refer it sometimes. Sometimes they perform cesareans at their end. But such fetus who have been a part of obstructed labor, trust me, their revival, their resuscitation is a challenge. And of course, the long-term morbidities for these mothers, the perineal injuries to the fetus, I mean, that's something which needs to be discussed. It's the call of the day. And Anupma once again, I have worked with her as when I was Dean MGM, and I find her one of the most learned and sincere persons in Indore Medical College. So she's again the right person. And once again, I have to compliment choice of chairpersons, Manik and Jagrati. Again, the people who must be dealing with such cases off and on. Sneha, the panel you're moderating, again, you have very learned people, Jyoti, Shaban, Deepti, again, my favorite PG, Aditi, Shruti. So all these people are the right kind of panelists. So beautiful choice of topics. Kavita Bapat, you missed me. I told that this is my incoming president. और मैंने बोला मेरी बात सही हो जाती है. So, but again, having said that, once again, my compliments to Sneha for choosing a brilliant topic, for having such learned speakers and chairpersons. And once again, I feel very obliged to be a part of this webinar. Brajbala and Jyoti will, as always, do brilliant work of coordination. Thank you once again, and I wish you all the best.
Thank you.
Thank you so much, madam. Over to you, Pam, for
Yes.
introducing our next guest of honor.
Thank you. After that wonderful blessings from Dr. Jyoti Bindal, now we are feeling so high. The world is ours now. Kudos to Kavita. And I have the privilege of now introducing a guest of honor, our favorite VP, Asha ma'am, Asha Bakshi ma'am. She's another one who's really so popular everywhere. Even in IAC committee, she's our VP. So she's MSFICOG, FRCOG UK. Still so humble and soft-spoken. Lead consultant at Asha Bakshi Fertility Center in association with Motherhood Hospitals Indore. She's current VC, Vice President, 2022 West Zone, Foxy, our zone, Treasurer ISAR 2021, member of Executive Committee, AIRCOG West Zone, Founder Chairperson MP, IAG MP ISAR, Chairperson of Foxy Infertility Committee, member of ICOG Governing Council 2020, past President IOGS. To her credit goes the first ICSI, TISA, ICSI, Micro TISI, and today, by chance, today is the IVF day. So, yes, hail, Madam Asha Bakshi, ma'am. We are so lucky and proud of you. Recipient of Kumud Tamaskar Award. She has organized many conferences and organizing chairperson AICOG, which we have witnessed. And over to you, ma'am. Welcome, ma'am. Please bless us.
Good afternoon, everybody. Madam just went to OT for some emergency. She'll be back in a while. Yeah.
Okay.
So, sorry for inconvenience.
No, we'll wait for her. And now I hand over to Dr. Braj. Dr. Braj, to welcome Dr. Archana Baser, ma'am. Dr. Kavita Bapat, ma'am.
Good evening.
Dr. Braj Bala.
Good evening, Pardesi sir, Bindal madam, all the guests, and our brilliant 3Bs, and my dear friend Dr. Sneha Bhuyar. So for this wonderful AMOX webinar on very important topic, it's my humble privilege to introduce our incoming President Foxy, Dr. Kavita Bapat madam. And madam is having so many feathers in her cape. She is the director of Bapat Hospital Indore.
Bus.
Secretary. So everyone is know about you, Kavita Devi, but two things I would like to highlight. A beautiful grandmother, you doesn't look like that. So we all.
Thank you so much, Beta. Thank you so much.
Only one adjective.
Yeah.
Kavita, one adjective for you. You are charismatic, and that is what a leader needs.
Thank you so much.
You attract us so much.
Thank you. Hey, thank you so much, Sneha. You are the Madhya Pradesh family. So you don't worry about anything. All the Madhya Pradesh is going to support you. Just don't worry about you. The way you have worked out, and we are for you. So don't worry about anything. So thank you so much for making us guest of honors with a हमारी अपनी Bindal madam. But first of all, I would like to say a few things about Rajendra Singh Pardesi. I am telling you, Bindal madam, if you would have listened him as a presidential address in MOGS, in a Maharashtra Association, you would have been surprised the way he is, the visionary leader, the amazing points and the solid points. He has got the solid points, how to take out the medical legal things, how to take out the membership things, how to take out the things, and how the way he puts things is a solid leader, and how he is inclusive of everyone. The taking names of people, I think I'm amazing, lot to learn from you, and that your lecture was really, really a learning thing for me. So it's really the great Pardesi sir, and you are not with us for last few days or a few months. We know each other for, I think, more than 20 years. So I know how you have worked, how you put the things, and a great leader you are. I mean, I'm not praising because I need to praise, but you are. I have seen your style of working. And another thing is my own Bindal Didi. आए दिन हमारी लड़ाई भी हो जाती है. But at the end of the day, we love each other. Honestly, because I have learned so much from her. The day is, and जब मुझे गुस्सा होना होता है तब भी मैं उनको बोलती हूँ, और मेरे को कुछ उनको दिल से बोलना होता है तब भी मैं उनको बोलती हूँ. So I think she is the pillar, the strength of not only the we people but all the Madhya Pradesh. I am finding it. And Asha Didi और बसेर के बारे में कुछ बोलने से लगता है बहुत ज्यादा मैं झूठ बोलूंगी. So I'm not बोलूंगी, कुछ भी नहीं बोलूंगी. We are together, and I'm love to see all my Madhya Pradesh people over here. And we are going to do the town hall with a presidential candidate on 30th. 5 p.m. So I love to have all of you on that program, the town hall with presidential candidate. It will be unique program. Ask me the questions and that will be the result. And I'll put it the flyers very soon. So love you to see everyone over there. And the Sneha, the topic, I don't take much time because I'm not a person who speaks long way. But I think it's a valuable learning opportunity for each and everyone who is over there. And it leads to the improvement at the end of the day. Obstetric care ka improvement chahiye humko, kisi and the patient safety. And the near miss, you people see many more cases like all the HODs and everyone from the medical college. But I think when to refer and when to not to refer by the private people is another important thing, because they should also know everything. And for that, we need the importance of early recognition. The best is the effective communication, because these are the patients we end up into the medical legal things. They make you to go into the medical things, and the prompt intervention that ensure the best possible outcomes, and both for the mother and the baby. So an excellent topic, and love to see you all. And best of luck, Neha, with me. And my own two young buddy sisters are there, Raj and Jyoti. But I give all the credit today to the Palm. She knows how to conduct the program with all
enthusiasm.
With enthusiasm and thank you so much, each and everyone being with me. I'm finding Shruti and Anu and everyone jinhone video khole hain, and Sunita is over there, and everyone. Or the Vrinda has gone, she is there. Okay, thank you so much. Thank you so much. Kavita, bye. Thank you so much. I'm here. Over to you, Pam.
Thank you, Dr. Kavita. Dr. Jyoti Banglowala, are you there?
Madam, Asha Bakshi madam is there, so please take her.
Acha, okay. Asha Bakshi ma'am, welcome. I just introduced you. Madam, we need your blessings and your words of wisdom. Asha ma'am.
Sure. Thank you very much, Pam, for the kind introduction and for bearing with me because of my absence. But Kavita gave such a good talk that I'm so impressed. I feel, Kavita, you deserve to be a president now.
घर वाले सर्टिफिकेट देने लगे हैं.
वो सबसे आखिरी में देते हैं, ये भी सुन लेना, हम सबसे बड़े क्रिटिक होते हैं हमारे. Right. So first of all, my greetings to Dr. Pardesi for such a good vision, and to Dr. Sujata Dalvi, Dr. Kiran, and MOGS is really doing good work. And Dr. Rajendra Pardesi, we all know him. He is like a parivarik person, हमारे परिवार के जो head होते हैं उस type के. So thank you very much for this such a good program. And Sneha, this is you are working very well as chairperson medical committee of MOGS, and I wish all the best for your future endeavor. So nice that Madam Jyoti. So nice that Madam Jyoti Bindal is also there, and we had the chance to hear her. Thank you very much, Jyoti Madam. And of course, Kavita, you're too good, and I want you to be even better. So I'm sure you are going to do very well, and wishing you all the very best for your upcoming elections. And our wishes are with you. And I would like to thank Dr. Pam for conducting the program so well. And today the speakers are so good. Dr. Kavita and Dr. Sneha is going to conduct the panel, and Dr. Shashi. I think this program is going to be wonderful. And especially the obstetrics is close to everyone's heart, whether it is obstetrician, whether it is IVF specialist, our all outcome depends on how well the obstetric part is conducted and how well you give the ultimate result, that is a healthy mother and healthy child. And my best wishes to all the contestants who are going in for election now. Dr. Bijbala Tiwari, we all know her capacity, how well she conducts the program, how deep she goes into whatever she does. She's very focused and very influential also, and very resourceful.
Resourceful.
She's very resourceful also. So my best wishes to Braj and to Jyoti. Jyoti ko to hum jante ही हैं. And medical legal के लिए Jyoti is one of the most appropriate person, because ins and outs. Any problem you talk to Jyoti, Jyoti, what's this? And she has an answer to it. And Sneha, I think you have already proven it while you were working as a chairperson breast committee. So I'm sure you are going to do a wonderful job. And Shashi, my best wishes to you also. You are so deserving. So I'm sure everyone is going to do well. And this is our home front. Mostly all the people are from MP. So my greetings to all of you, and thank you so much for inviting me.
Thank you. Thank you, ma'am. Shabakshi, ma'am, always a pleasure to listen to you. And so much to do with you. And really, it's a great day. We have from Bindal madam to all three of you. So now the last but not the least, the most interesting Jyoti, can you introduce Archana Basir, ma'am?
Yes, ma'am. Yes, ma'am. And this is actually my proud privilege to be with the dais with our own people, all stars of MP. And I want to extend my thanks to Sneha Buyar madam, Dr. Rajendra Singh Pardesi, and Dr. Sujata Kar, and Dr. Kiran Kurkoti sir. And Pardesi sir, as Kavita madam told in her previous talk, he is just like a big brother. Always he says, these are my younger sisters, and always, if you are asking or not asking, he is always texting you about your mistakes, about your guiding you. Ideally, he is guiding everything about the medical legal whenever I post something. I am so thankful, sir, for being with us always. And all our 3Bs, these are 3 elder sisters who hold our hands since the beginning. We have entered in the Indore society. These are the ladies, Dr. Kavita Bapat madam, Dr. Asha Bakshi madam, Dr. Archana Basir madam. They are like our family. All the time they are with us. All the time they are guiding to us. And what to say about Jyoti Bindal madam? Jyoti Bindal madam is the epitome of grace. She is for us every time. There are too many seniors here. The very special seniors, Dr. Kavita Singh madam and Dr. Anupama Dave madam, the president and secretaries of our society. I am so proud today. Our MP is shining like anything. And this is my humble opportunity to present the CV of Dr. Archana Basir madam. Actually, Archana Basir madam is the very accomplished gynecologist. She is the epitome of
Jyoti ma'am?
Jyoti, can't hear you.
Some net issue is going on.
Some problem with our
Okay.
network, I think.
Even if
Okay.
my place.
You can go ahead and
Doctor. Yeah, I'll introduce Madam Archana Basir, ma'am.
I think Pam, I think it's enough. I think everyone has read it and people know us. So it's really, we are humbled by you reading our CV. So I
No.
think it's really an honor and privilege to be here on combined MPOG and MOX program and the topics are too good. And I mean, you conducting the program is par excellence. And it is really good to share the stage with stalwarts of MP, Dr. Jyoti Bindal, Dr. Kavita Bapat, Dr. Asha Bakshi, and the AMOX president, Dr. Pardesi, and the team of Dr. Pardesi, and the most of all, Sneha Bhuyar. The love she shows when she calls you, it's really, it's like you are talking to your sister. So Sneha, all the best to you, and the topic you've chosen are really two good topics. And everyone present here, I think, is going to get benefited by the topics. I think lot has been talked about the topics which you are going to be covering, so I need not repeat all the topics, but my all the best to everyone here, those who are speakers and listeners, and all the best to all the contestants. Brajbala, she is too good. If you know that she was the first lady secretary of IMA, which is the mains field. Dr. Jyoti Banglowala, I have seen her grow, and the way she has matured and she has emerged as a very accomplished medical legal consultant, I should say. And the way she has been handling the things and the way she is doing webinars, I think it is really a good seeing them all grow. And all the contestants who are contesting for the elections, all the very best to all of you. Do your best and give your best. So that's what my really saying to all of you. And enjoy the webinar, learn, and do take some take-home messages. Thank you very much for inviting me to this program.
Thank you. Thank you, Basir Madam. Thank you very much. And now
Yeah, thank you. Thank you, respected Dr. Pardesi sir and Madam Sujata Darvi, our ICOG office bearers, Dr. Lakshmi Shikhande and Secretary Dr. Ashok Kumar. Of course, Madam Nandita Parshidkar, the immediate past president of AMOX, Dr. Kiran Kurtakoti, the president-elect of AMOX, chief guest of today's program, Madam Jyoti Bindal, and our guest of honor, the three Ps, Dr. Asha Bakshi, Dr. Archana Basir, and Dr. Kavita Bapat, and the entire team for today's program, the speakers, the chairperson, the faculties, the moderators. I thank all of you. Thank you for your gracious presence and your precious words. And over to you, Dr. Jyoti and Braj, for the academic session now. Thank you, Dr. Palm, for wonderfully moderating the inaugural session. Thank you so much.
Thank you. Thank you, Sneha ma'am. And now we are going to have a very, very important scientific sessions, our as prolific speakers, Dr. Kavita Singh ma'am for the first session, and Dr. Adipapa Dave. And we are obstetricians. The public knows us by our obstetric capabilities. So the topic today is very interesting. We will all be glued, and I now invite Dr. Brajbala to introduce all the chairpersons.
Thank
for
you.
This first session.
Thank you, Dr. Shashibala madam, and thanks to Pardesi sir, Bindal madam, Bakshi madam, Basen madam, Kavita didi, everyone for blessing this occasion and to bless for the contesting election. So we are going to start our academic session, and for first session we are having chairpersons, eminent professors from our own state, Dr. Madhuri Chandra madam. She is former professor and unit head OBGY, Gandhi Medical College, Bhopal. She is ICOG Governing Council member 2017-2020, President Bhopal Menopause Chapter 2020, Chairperson HIV/AIDS Committee FOXY 2014-16. She is President AMPOC Research and Public Welfare Society 15-17, and she had published papers in international and national journal, published papers in many conferences, and she contributed chapters in textbooks of OBGY. So I welcome you, Madhuri Chandra madam. And next chairperson is Dr. Brinda Joshi madam. Madam is from Gwalior, and madam is president Gwalior Society. She had so many gold medal, first in university, and she had FICOG 2006. She is medical teacher for last 26 years, National Ethicon Traveling Fellowship, FOXY 2002 to 2003. She had been awarded many times, basic course in biomedical research, National Young Scientist Award for North Zone, 2 book chapters, 23 research publications, and she had so many responsible posts. She's online training of medical officers on maternal health, state trainer cervical cancer screening, and member of medical board for termination of pregnancy. So I welcome Vrinda Joshi madam. The next chairperson is Dr. Anita Shrivastava madam. Madam is President OBGY Society Bhopal 23-25. She is PG from Government Medical College Jabalpur, and she is Associate Professor at Chirayu Medical College Hospital Bhopal, past Vice President Secretary, Joint Secretary of OBGY Society Bhopal, and she's trained in advanced gynae laparoscopic surgery, and she has special interest in routine OBGY, high-risk pregnancy, adolescent health, and cosmetic gynecology. So I welcome you, Anita Shrivastava madam. Now I request all the chairpersons to introduce our speaker, my very best friend, Dr. Kavita Ansi. Over to you, all the chairpersons.
Thank you, Dr. Brijbala. I believe I am to introduce Dr. Kavita Singh, a great friend and also the professor and HOD of Obstetrics and Gynae at Medical College Jabalpur. She is a WHO master trainer in colposcopy and gynae surgeon. She is the organizing chairperson of MPOX 2013, IOGIN 2013, Foxy Zonal Conference with UA 2022. She's been the past president of the Jabalpur Obstetrics and Gynae Society, MTA, Rotary Club of Jabalpur, and the state secretary of MPOX. Has more than 15 state and national awards, more than 45 index publications, textbook chapters, international scientific monograms on colposcopy. She's a PhD guide for gynec-oncology and a passionate teacher of more than 23 years. Kavita.
Hello. Good evening.
Good evening.
Can you hear me?
Yes.
Can I share my slides? If you allow me.
Yes, ma'am, you can share.
Okay. So very good evening to all of you. A wonderful evening, and my regards to all the MOX and MPOX and ICOG office bearers. And a very good evening to the kind introduction by Professor Dr. Madhuri Chandra madam, my friend Dr. Vranda and Dr. Anita as chairperson. And I can see the president of Jabalpur OBGYN Society, Dr. Manik, and Deepthi also in the panel as a secretary, JOX. So I think now I should start straightway, go to the presentation.
Yes, Kavita, can I interrupt you?
Yeah.
Put your slides on full screen.
Full screen, okay. Just a minute. Wait program to respond.
Just kindly reshare it.
Yeah. No. I'm putting it on the full screen. आ रहा है क्या? दिखाई दे रहा है?
No, it's not full screen, Kavita.
नहीं दिख रहा है?
नहीं, full screen नहीं है अभी.
Screen नहीं दिख रहा है?
No, we can see your slides, madam.
Never mind, हम लोग चश्मा पहन लेते हैं.
नहीं अभी दिखेगा.
Just you can reshare once.
Reshare करती हूँ. एक बंद करना, एक ऑन करना. अभी या फिर से रीशेयर करें. डेस्कटॉप. फिर से नीचे जाते हैं. पहली बॉटम आएगा, है ना? पहली बॉटम. No.
Ma'am, at first, please open the PPT.
अभी दिख रहा है
and
नहीं
then,
दिख रहा है?
share
No,
screen.
madam, we are not visualizing your screen at all. So
कुछ दिख रहा है कि बंद हो गया?
no, we can see you only. That's
मैं
all.
एक काम करती हूँ, मुझे मेरा स्लाइड्स दिख रहे हैं, मैं
Share screen, madam. You have opened the presentation. Now you minimize it. Yes, now we can see.
Is it okay now?
Yes, ma'am.
Yeah. I think it will work if it's
Slide show कर रही हूँ.
Yeah, slide show only now.
Your topic is so interesting.
Actually,
so
जब भी जैसे ही
it will
स्लाइड
work.
शो करते हैं ना, स्लाइड शो करते हैं तो वो स्क्रीन चला जाता है. वो छोटा स्क्रीन में आपको चलेगा क्या?
You share it on the group, Dr. Sathi. She can
Close,
share
wait
otherwise.
for the. अब वो बार-बार बोलता है wait for the program to respond.
Kavita, it's okay.
चलेगा,
it's okay.
we can
We
read
can
it,
read it.
Kavita. We can read it, but you know, if you can just उसमें नीचे देखो लिखा होगा.
मैडम अभी वो हैंग हो रहा है जल्दी जल्दी बटन्स दबाने में.
Okay, that's okay.
It's okay. I think we can see it. No problem, madam.
We
We
can
can
see
start.
आप लोगों को वो जहाँ पे दिख रहा था ना जूम में, छोटा ही दिख रहा है. हम लोग छोटा ही दिखा रहे हैं आपको, ठीक है? छोटा ही दिखा रहे स्लाइड शेयर.
दिख रहा है, सब दिख रहा है.
फिर से चला गया कविता.
वापस गया ना वो नहीं है. अच्छा अभी आया क्या?
नहीं कविता,
अच्छा
आपका फोटोग्राफ दिख रहा है, आपकी शक्ल दिख रही है.
शेयर अभी
हाँ अब दिख रहा है.
अभी ठीक है.
You can continue like
This will work, madam.
अभी
It
ठीक है.
will continue. Yes.
Is it okay?
Yes.
Yeah.
Because if I'll put it on the slide share now, it will go. It becomes white. The screen becomes white. तो मैं यहाँ से वीडियो बंद कर दूं क्या कि चलने दो?
नहीं चलने दीजिए.
अच्छा. So greetings from Netaji Subhash Chandra Bose Medical College, Jabalpur. I'm happy to be speaking on this, and I'm really thankful to Dr. Palm. A day before yesterday, I think 2 days back, she said कि मैडम आपको कुछ बोलना है, and I said चलो अभी as a speaker बोल रहे तो चलो चलते हैं. So I said okay, she wanted something on obstetric call. So I said okay, last Monday only I've done a peripartum cesarean hysterectomy, so I'll share whatever it is. So with this, is my screen seen to all now? I'm not able to see you. आप लोग को चेहरा नहीं दिख रहे.
हाँ स्क्रीन दिख रहा है.
दिख रहा है.
हाँ, we are able to read
Madam
it.
दिख रहा है. आप बोलिए.
see it.
अच्छा. Okay. So by definition, we all know that emergency peripartum hysterectomy which is done within 24 hours of vaginal or cesarean delivery, and it is the most demanding surgery in a most crucial time to save her life. Earlier, when we were students, all of you would agree that atony was the reason for which we used to do cesarean hysterectomies, and we have seen our teachers doing it, or it was sometimes rupture uterus or sometimes sepsis. But now from atony, it has gone to placental adherence, which is the trend following the rise in cesarean section. Emergency peripartum hysterectomy is the most dramatic operation in modern obstetrics and generally performed when conservative management fails. Secondary to life-threatening hemorrhage following vaginal and cesarean delivery, performed as a last resort. We all know that. As far as the little history is concerned, it was started way back. It was first introduced in animals in 1768, and by 1876, surgery was done where the both mother and the newborn were survived. The incidence varies from 0.2 to 8.7 per 1,000 deliveries. And the incidence of placental adherence or morbidly adherent placenta is 45 to 75% from various studies. It is different in different studies. 20 to 40% atony is the reason, and in 10 to 25% rupture and trauma is the reason. So anticipation of risk factor is the most important thing in if we have to start on the preventive aspect. So whenever we come across a scarred uterus scar in form of any scar, right from minor procedures to multiple myomectomies or cesarean sections, hysterectomies, and so on. Multiparity elderly patients, they are more at risk. If the patients are anemic or there is history of neglected delivery, or this time it is a neglected delivery, I would say it is an indication. We'll be listening more on obstructed labor in the coming session 2. So in emergency peripartum cesarean hysterectomy, senior OB/GYN around at should be around in the tertiary center. So the center should be tertiary center and the senior people should be around with other friends also. So cesarean hysterectomy and resuscitation goes hand in hand. So on one side, we are going ahead with a cesarean hysterectomy. At the same time, resuscitation part is taken care by our anesthetist friend. Now, what I feel and what I believe, that not allowing to bleed. It is not that she bleeds and then we go ahead. Not allowing to bleed by the way of meticulous planning antepartum or intrapartum, skilled steps and prompt surgery. And this is the answer for today's emergency peripartum cesarean hysterectomies. And we have evolved in so many years, and gradually after 24 years of working in medical college, we are able to manage almost every week. We are getting, I'm really sorry to say that we are getting so many cases of morbidly adherent placenta, and many a times they end up like this. So I'm just presenting a case which came last Monday. I think this is the time, 5:30. Yes, 5:30. I was in theater. Patient was presented to our district hospital on 17/7 in the morning with a pain and in abdomen and bleeding per vaginum. She was gravida 3, para 2, live 2. First was her vaginal delivery. Second was her cesarean section at same district hospital. She was not aware of her last menstrual period, but she had 2 ultrasound with her, which were done in the district hospital, and it was 38 weeks plus weeks with cesarean section with APH was an presenting complaint. It was not there anything on the ultrasound. So immediately the patient was taken for cesarean section in the district hospital, considering it to be an previous cesarean section and with bleeding per vaginum. So obvious, it is a very straight away decision to go ahead with cesarean section. Now, what happened in between that time, I'll just narrate a little while. In afternoon around 4 p.m, case was referred to us with history of taking this patient in operation theater at district hospital. They opened up with a previous transverse incision only and found that the entire lower segment to half of the uterus was covered with a large tortuous dilated blood vessels. And the team which was there to do in cesarean section and the friends around, they all decided to close the patient without touching it, and with fetus in situ, this patient was referred to us. And while referring the district hospital people, so we know each other, so they shared an intro of finding picture to our PGs as well, that this is one patient we are sending and it is not wise to touch this patient. So this picture was forwarded to me that day. Last Monday was our HPV detection camp. So after camp, I reached around 4 at home, was taking my meal, afternoon lunch, and then I saw this picture. So this was the picture which was shared on the mobile. Here you can see the transverse incision showing a large tortuous blood vessels, and the bladder is all adherent and showing the vessel. So this is a picture of the same patient on our OT table. Here you can see the bulge and the fullness in the abdomen, in the flanks, and it is right from the Xiphi sternum to the pubic symphysis. This was the incision which was given by our friends in district hospital, and they closed and sent this patient to us. So when I assessed, immediately when I saw this picture, the earlier picture on the mobile, I decided myself I got my SR told me, Madam Deepti Madam, Archana Madam nikal gaye hain. So I said, ask them to take me along because I anticipated a torrential bleed. So I said I would also join. So I went to the hospital. And on examination, I found that it is not wise to reopen from this place. So I gave a midline vertical incision because the baby was there. I could feel the podalic pole in the close to the in the xiphisternum, say around 40 weeks size the uterus was, and the baby was very healthy. So the delivery was conducted. If I am able to show you video, I'll show you. And the delivery was conducted. The baby was 3.8 kg, cried immediately. Baby was handed over. After handing over the baby, this was the incision. Just you can zoom into the picture and see that it is given very high off, even above the insertion of round ligaments. This is Webb's incision. And by this incision, the baby was delivered. And when I delivered and had clamped cord and handed over to pediatrician team, I could make out that the placental edges were reaching even this high. So I could feel the edges of the placenta there. And immediately in the 2 layers, I closed this abdomen, this uterus. And after closing, the uterus was lifted out like this. And the next step was, in this case, was we learn about prophylactic bilateral uterine artery ligation. So this was done in this case before touching anything else. So I ligated on both the sides and then started doing stepwise cesarean hysterectomy as we do. And you can see there is no point doing subtotal. You have to go deep down, deep down, deep down. You have to lateral cams and then you should reach the vagina. In this case, we were able to reach the vagina, the entire placenta and everything, the specimen, everything was absolutely clear. The vaginal vault was clear. When we saw the vaginal vault, it was not showing any placenta and everything went off well. The bladder dissection was tough, but we were able to do it and could reach to the base of the bladder. We traced the ureter on both the sides. Being an oncosurgeon, it has become my habit only to all difficult cases, whether they are retroperitoneal tumors or broad ligamentary masses or cesarean hysterectomies. I always trace ureter. So the ureters was shifted laterally. The bladder was pushed down, and we could do a cesarean hysterectomy. And when we closed the vault, and meantime we found that the bladder started, filling up, so that the dome was rising. The dome was rising, and we saw that when we pressed the bladder, we found that the blood was coming, frank blood was coming from the urethra. So because our ultrasonologist had already told us that there are perforators from the, in the bladder also. So, but we dissected well. So we were thinking कि हमने तो अच्छे से dissection कर दिया, अभी ये कहाँ से आ रहा है, चलो ठीक है. So and now we are working in a hospital where we have a super specialty block in our premises, and we have all the entire urology department around. So we called up one person from there that meantime we'll open. So we opened the bladder. I opened myself and removed the clots and repaired the bladder, extended. What I realized that while putting the clamp on my side, the last clamp, maybe few fibers of the bladder pillar were oozing. So I took 2-3 bites, and maybe on that the bladder mucosa was caught. And there were multiple bleeders, tortuous vessels, which were not only traversing to the lower segment cervix, but into the bladder also. So we opened up, removed the clot, and stitched in 2 layers. Intraperitoneal drain was kept, SPC was kept, PUC was kept for draining, and post-op patient when was comfortable, he received 2 units of transfusion. And on third day, she was all well. Today also she is doing well with SPC and periurethral catheter. We have in today morning, we have taken rounds and we'll be removing it tomorrow. Mother and baby both are well. Video, I'll see if I can show you, because in the webinars, there are at times there is problem. So this is today's picture. Here you can see the patient is sitting with the baby, and here this is the periurethral catheter and this is the SPC. So tomorrow we'll take out the SPC. Now here I wanted to share something for all the friends. All are learned friends, but we learn by sharing. That triple P procedure, which is used for conservative surgery, that perioperative placental localization and delivery of the fetus via transverse uterine incision above the upper border of placenta should be done. So for that, this is a calm and without the chaos surgery. So first thing is you have to take a liberal vertical incision. See carefully what you are able to make out, and then put your transverse incision above the upper border. It would be difficult because it is thick upper segment incision, so delivery is difficult. That is why we seniors are needed to handle such cases. Pelvic devascularization, which is done for the focal, we are using triple P procedure mainly for the conservative surgery when there is a focal infiltration into the myometrium. So you can excise that part and do the repair. But I feel that even in all such cases, we should do pelvic devascularization. We did in our case, in the previous 5-6 cases also, which recently I've done. Pelvic devascularization we do as in prophylaxis. So prophylaxis, whatever placental blood is there, it is there. Or you can say the perforators which are coming, they will be using. Otherwise, you are obliterating the supply to the uterus. So the placental null separation with the myometrial excision and reconstruction of the wall, which is done in the focal case. This I have done in 2008 in one case, which was published also in Foxy Journal. So, so this we have to keep in mind, even in cases of emergency peripartum hysterectomy. So what is the lesson learned from this case for all of us? This patient was in booked case. This patient was in booked lady where she was reaching district hospital, but morbidly adherent placenta was missed, I would say. Antenatal care should be with caution when we get an alert findings on ultrasound that the placenta is anterior. So my all the delegates and all the youngsters and all the students who are there in the webinar, that whenever you come across an anterior placenta in a scarred uterus, आपके एंटीना खड़े हो जाने चाहिए और आपको तभी मतलब सोचना चाहिए कि इसमें हमको MAP rule out करना है, adherence rule out करना है. So in this case, obstetric USG was done on in May also, showing anterior placenta with polyhydramnios. Then the last ultrasound which she was referred to us with, which was done on 26, मतलब अभी थोड़े दिन पहले ही हुआ था, और no sorry 26 June को, 7 नहीं June को, and the fetus was 3.8 kg with an anterior placenta. Further investigation was not done to rule out adherence, which I think is again missed, and it is an usual practice. ऐसा नहीं है कि यहाँ पे मिस हुआ, ऐसा मैंने और भी बहुत सारे केसेस में देखा है, पहले भी देखा है. पहले भी जो केसेस आए हैं तो उसमें यूजुअली कहीं ना कहीं हमारा स्कार्ड यूट्रस पे हमारा उतना ध्यान नहीं जाता है कि where is the placental implantation. So that is very, 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 very important point to be taken from this webinar and this particular case. Incision should have been vertical for such case. That is my opinion, because they reopened it when low transverse, where realizing the baby is reaching up to the Xiphi sternum. So whenever you have to do manipulations and you have to deal the emergency, vertical is always good. Howsoever, or maybe anyhow, आप कितने भी senior रहो, but this is advisable. And follow triple P technique prior to EPH. तो triple P करने से ना बहुत शांति हो जाती है, bleed ही नहीं करता. जब आप cesarean hysterectomy करेंगे तो it hardly bleeds. And this has happened in our case also. So do not, worry too much for the bladder management in EPH, because here you are saving life. You're not worried about bowel, bladder. So if you have an efficient senior OBGYN around you, or some surgeon or urologist, don't hesitate. In this case, I myself opened and repaired. Earlier also, I have repaired so many, and now my associates and my team have started handling such bladder injuries very smartly. So this is the important lesson from here. So EPH is a life-saving emergency procedure. Unplanned nature of surgery, that is biggest problem कि एकदम आया फिर एकदम समझ नहीं आया, कहीं पे भी क्लैम्प्स लगा दिए, वो नहीं करना है हमको। ट्रिपल पी को फॉलो करना है और शांति रखना है। इन एक्सपीरियंस सब ऑप्टिमल एक्सपीरियंस और एक्यूट ब्लड लॉस रिस्पॉन्सिबल फॉर ये सब चीजें जब रहेंगी तो देयर आर मेनी चांसेस दैट यू विल लूज योर पेशेंट ऑन टेबल इटसेल्फ। रिस्क फैक्टर इवैल्यूएशन शुड बी डन इन एंटीपार्टम एज वेल एज इन द इंट्रापार्टम। तो एंटीपार्टम में भी अगर मिस भी हो गया तो इंट्रापार्टम में शांति से देख लो कि क्या है। And adequate resuscitation and prompt steps to deal the situation. We hardly took 50 minutes to complete the procedure, including the bladder repairs. 1 घंटे के अंदर मेरे assistants ने बोला कि मैडम अभी तो हमारा normal Caesar का time हुआ है and we are through. So promptness is very important. You have to maintain time, you have to maintain the patient, and with post-operatively 2 blood उसको लगाना पड़ा. Multidisciplinary approach is the boon. So I thank convener of this webinar and all my chairpersons for patient listening. Now I will again come in front of video. This is my team. उस दिन जो मेरे साथ में witness किए हैं, आप इन लोग से और कुछ पूछना है तो इन लोग से भी पूछ सकते हैं. So ये लोग खुश हैं क्योंकि patient इनको सीखने को भी मिलता है and patient is also happy. So here I am and I am open to all the questions to all of you. एक ही केस बता रही हूँ, अभी कभी कॉन्फ्रेंस होगा तो मेरे पास बहुत मटेरियल है, बहुत सारा शेयर करने के लिए.
Okay, thank you, Dr. Kavita. This is Vrinda speaking, and as always, it has been a very nice pictorial presentation, and it is very prudent of you to have taken pictures at every step. That makes it a nice presentation.
अरे इन लोगों ने ना ब्लैडर के टाइम नहीं लिया वृंदा, ब्लैडर जब ओपन किया ना इन लोगों ने नहीं लिया. तो बाद में इनको बोल रही थी कि तुम लोगों ने मैंने जब ब्लैडर ओपन किया वो क्यों नहीं लिया. बोले मैडम हम उसको इतने ध्यान से देखने में लग गए कि पिक्चर लेने का उस टाइम पे भूल गए. So it happens, but it is all credit to my postgraduates.
Yes, and I also want to share the same thing, that this incidence of adherent placenta is so common now that it's, again, we would not say it's a boon, but almost every associate professor in the department also knows now how to go about doing hysterectomy, this peripartum hysterectomy in adherent placentae. And one important thing is what we observed is the bladder, often it has the posterior surface, it has big bleeders. And this we learned from our previous few experiences, that nothing short of undermining it closes the bleed.
Yes. Yes. Even at the time of closing, when we were closing, we found, say around 3 to 4 centimeter deep down, there were one spurter. So we have managed it. So perforators are there. In such cases, they are actually challenging, no doubt about it. They give us tough time, but we are tougher than the situations. And this is how we learn and we save.
Dr. Kavita, I also appreciate you for presenting this topic in such an interesting way and such a nice way. You are a brilliant obstetric teacher.
Thank you.
I'm working here with Dr. Archana Mishra for reducing MMR in MP. And from this presentation, I just learned the same strategy has to be followed in every case. For example, referring the patient in time, referring in a proper way, giving the history to the proper place, simultaneously doing resuscitation and surgery by senior gynecologist, keeping all the complications in mind, which can save the life of the patient. We are all about working for saving the life of these patients in the tertiary center. Very nice presentation. Thank you. Thanks a lot.
Thank you so much. And thank you, Jyoti Didi, for calling me President-elect of MPOX.
Yes, you will be
So
one
Dr.
day.
Manik and Dr. Deepti, you have congratulations to you. It is coming in your tenure.
Excellent
We had
Thank you. Thank you, Kavita.
बहुत सारा सीखना है अभी ग्वालियर से हम
Madam
लोगों को।
Kavita Singh, excellent presentation and thanks for accepting our invitation. In fact, I was supposed to invite you, but I told Jyoti and Pam that you please talk to Madam so that, you know, if she doesn't have my number, she may not receive the call. So,
Thank you, madam. Thank you so much. Thank you so much. And you know, सब लोग मिलके जरा इस बार MP सरकार कर दो।
Madam, it's all in the voters.
मैडम आपके महाराष्ट्र में भी बोल देना ना मैडम, आप हर बारी तो बन जाते हो सभी महाराष्ट्र वाले, कोलकाता वाले, दिल्ली वाले और सब वाले। हम बेचारे हम लोग ना सेंट्रली नेक्रोज्ड एरिया वाले जो अपने MP वाले जबलपुर वाले, तो मेरी दो सहेलियां मेरी जूनियर सब बैठे हुए हैं यहाँ पे, सबको भैया MP वालों को दे दो, सब लोग।
I just want to say one thing, that without any regionalism, I just say that genuine hard-working people should come forward. That is all, and that's in all of your hands. So,
thank you, Madhuri Didi. Thank you, Nanda, and
all of you on our behalf. Thank you so much.
Yeah, sure. Thank you, my chairpersons, and thank you, everyone. Thank you so much.
Thank you, Kavita ma'am. Thank you.
Thank you.
Thank you, ma'am, for inviting us. Madam, once again, I'll wish you all the best luck.
Thank you so much, madam. Thank you.
So, shall we go to second session, madam?
Yes, definitely.
Yes. So our second session is the obstructed labor and overview. Actually, the cut two speaker and those both the speaker are my seniors, Dr. Kavita Singh and now Dr. Anupama Dave. They both talked us of so many things. And for this, I am inviting as the chairperson, Dr. Mrs. Panse. She is the senior obstetrician and gynecologist and director of Anant Multi-Speciality Hospital. She is the president, Innerville Rotary South, and president of Jabalpur Obs-Gynae Society in this current year. She is the member of Camarec Trust merged in the Virat Hospice for the terminally ill cancer patient and ex-member of RDVV. She is the executive council member of BOS Food and Nutrition, and she is involved in the College of Home Science.
It's okay.
Yes.
It's okay.
I welcome you, madam. Our second chairperson is Dr.
Thank you.
Jagrati Nagar. She is the president of Sagar Obs-Gynae Society and associate professor of Bundelkhand Medical College, Sagar, and winner of the Duru Shah and DK Tak Award as Secretary Sagar Obs-Gynae Society in Patna AICOG 2014. She is the winner of all 4 national awards as President Sagar Obs-Gynae Society in 2017 at Ahmedabad and as President in 2016 and part of organizing team of MPOX. She is having several publications and invited as faculty in several national and state level conferences. We welcome you, Jagrati madam. Our third chairperson is Dr. Sunita Wadhwani. She is at present president of Ratlam Obs-Gynae Society and director and consultant of Ratlam Hospital and Research Center. And she is a NABH assessor and she did MBA in hospital and healthcare. Her area of special interest is clinical obstetrics. She is the lead assessor and master trainer in Manyata by Foxy. I request Dr. Panse madam to introduce our esteemed speaker, Dr. Anupama Dave madam. And I request Sunita madam and Jagrati madam to open the topic and conclude the topic. So I am handing over mic to Panse madam.
Thank you, Jyoti. May I call you Dr. Jyoti?
Yes, ma'am. Jyoti bhi bolenge, madam, chalega.
I'm so overwhelmed. I'm so overwhelmed because I am with such a galaxy of stars from Maharashtra and MP. And on top of it, I am introducing Dr. Anupama Dave. My God, she's MR, COG, HCOG, and she is organizing Scientific Committee Chairperson, AICOG 2022 Indore. Presently President, ISOPAB, past Secretary, ISOPAB. If I cut short it, will it be okay?
Yes,
past
madam.
Secretary MPOX, past Secretary IMS, Organizing Secretary, National Conferences, IMS Con, past President Indore, Foxy 2010-11, active member of Indore Society last 20 years. In academic, she's having many UG and PG and teaching experience for last 29 years. She has lot many awards to her credit. Recipient of Foxy Sun International Traveling Fellowship, received ICOG Foreign Travel Award 2014, winner of prestigious Foxy Corion Award, winner dear Dr. C.S. Dawn, Best Paper Award 4 times. My God, एक मुझे दे दीजिए कल. And winner of Dr. Amendranath Dan Award, Umaram Prize for Best Paper, and she has a lot many. She's doing socially also. She is very active. She's master trainer and nodal officer for Foxy, master trainer for IPS, IPAS, publication 64 national and international journals, and her special interest is high-risk pregnancy and NDVH. I think we share similar interests. I'm also interested in high-risk pregnancy, and I do basic obstetrics and gynae. So your talk will be very much beneficial to me.
Thank you for the so very kind introduction.
Thank you.
Anupama Madam, I want to invite Dr. Jagrati Madam to just open your topic, Madam. Anupama Madam.
I do not have slide share, so how do I share my slides?
Madam, you are not host, Madam.
I don't know, slide share.
All the panelists can share the slide, ma'am.
Madam, Saiti Priya, please make
ma'am a green.
No, it's not coming. It's not coming on this.
Just a second.
Get it into a full screen mode, ma'am.
Yeah, just click on share screen option, ma'am.
Share screen option is not there in this.
Ma'am, on the view thing, now you click and get it into a full screen mode.
It is full screen.
Anupama Madam,
we can see that share screen logo.
Logo है ही नहीं.
मैडम है, मैडम चैट के बाद एक शेयर करके ऑप्शन आ रहा है इसमें.
नहीं है, चैट ओपन किया उसमें नहीं है, ओनली चैट है.
मैम आप डेलीगेट वाले इसमें से लॉग इन कर लिया क्या?
No. Ma'am is in panelists only. Faculty link only.
साहित्य एक मिनट आप मैडम को होस्ट बना दो.
Yes, ma'am, I have already made.
But still it's not showing. कुछ और करना है क्या?
मैडम एक बार आपको बनाते को होस्ट एक मिनट रुक जाइए, एक मिनट बनाते. Meanwhile, just I want to say, Anupama Madam and Kavita Madam जैसे पहले हमारे एकदम ऐसे सीनियर थे जो पूरे टाइम हमारा हाथ पकड़ के आगे चलते थे. And till date, we can see Anupama Madam and Kavita Madam, they all the time, they are actually protecting us and they want us to rise actually. Thank you, Anupama Madam and Kavita Madam. Thank you very much.
Still, it is not coming.
Ma'am, beside chat, there is an option called share screen.
Share screen, ma'am.
There is no such option. Should I log out and again log
हाँ
in?
मैडम, लॉग आउट करके लॉग इन कर लीजिए.
जो ईमेल आया था उससे लॉग इन किया था.
हाँ मैडम, आप एक बार पूरा लॉग आउट हो जाइए और फिर से पूरा लॉग इन हो जाए.
Otherwise, you can share the presentation to any one of us. We can.
Ma'am, I have shared my mail ID, or you can share in WhatsApp also.
नहीं मैडम, लॉग आउट हुए, वापस से लॉग इन होंगे तो हो जाएगा.
Meanwhile, I tell best of luck to all who are contesting. Jyoti, you, Brajbala, Kavita ma'am, everyone.
Very good.
Dr. Sneha Buyar.
Dr. Sneha Buyar.
Yes.
Yeah, sure.
So from Maharashtra, but we are contesting for the national post, madam, and all of us are from the same, I would say, same platform, Foxy. And I appeal to you humbly for my support to my candidature for Foxy Vice President. I purposefully avoided that saying that in the inaugural session because we all want to go ahead with the academic session. But I take this opportunity because we have the time right now. Thank you, madam.
It's time. I know.
So in fact, let me share with you all by the time, madam, I think
she's back.
Yes, she has joined, connecting to audio. Yeah, please.
Anupama Madam, Anupama Madam.
Please try sharing your screen.
Anu, I had sent you again.
No, still it is not coming. Can you send me the link again on email?
Anu, I sent you on WhatsApp. I will send you on mail. Okay.
No, but the link doesn't have this problem. Once you are logged in, you should get the option of share screen. Saiti, can you look into this matter?
Yes, ma'am.
Saiti?
Ma'am, Anupama, ma'am. I
Anu,
request you to share your slides to me, ma'am. I will share on behalf of you.
Yeah.
I have sent my mail ID in chat box.
And I sent you on mail, Anu. Link I again sent.
अभी left किया है मैडम ने, अभी left किया है.
But Saiti, do we face this problem that even when you are logged in and you don't have the option, you have made her co-host also, no?
Yes, ma'am. Till now, no one has got this problem.
That's the reason I thought maybe. Either she can share with any one of us and we can share for her.
Yes, ma'am. Now we can see your screen.
Now we can see.
Yes, ma'am.
Yes, now I again logged in, so that came out.
Yes, ma'am. Perfect, ma'am. Thank you.
So, a very good evening to all of you. My greetings to all seniors and friends. I would take some time here to thank Dr. Sneha and the organizers, Dr. Pam and Dr. Braj and Dr. Jyoti, for inviting me to this wonderful and enlightening CME. The topic is just too good and would be useful to all of us. And I also would like to say something else. As we have all stalwarts with us today, I take this opportunity to convey my best wishes to all contestants. As rightly said by Bindal ma'am, the future Foxy stakeholders, like future incoming President Dr. Bapat, future VP Dr. Sneha, and future chairpersons Dr. Braj and Jyoti, all the best, and so it shall be. We all are with you.
Thank you so much, madam.
Now moving on to the topic. It would be a short overview of obstructed labor, as nowadays we do see less cases of obstructed labor due to improvements in healthcare, but still in some cases whom we are contemplating normal vaginal delivery and we overexert, we may land up in obstructed labor. So a knowledge of this is essential. I begin by the quote, "The bravest battle that was ever fought, shall I tell you where and when? On the maps of the world you will find it not. It was fought by mothers of men." This is true for the olden days when you had to have a vaginal delivery, whatever may happen, even if it was a big baby or an obstructed or a bad pelvis, it would be a vaginal delivery. So that was the scenario then. Obstructed labor is considered a major failure of obstetric care. It is a big problem, especially in developing countries where antenatal care is not adequate. There are late referrals and unsupervised deliveries. The journey of the fetus through the pelvis is small, but you would agree that it is stressful for the obstetrician at times. There are temptations to expedite vaginal delivery in suboptimal conditions, and this is what leads to obstructed labor. We know these important terms like normal labor. If anything deviates from the normal definition, it becomes abnormal. But then prolonged labor is there when the combined duration of first and second stage is more than 18 hours. And this prolonged labor essentially at times leads to obstructed labor. Then the 3 Ps, as we always used to call it, power, passage, and passenger, are responsible for the whole process of labor. But now a fourth dimension has been added, psychology. Psychology also plays an important role. We know all the 3 stages of labor. This is the mechanism. Arrest at any one phase may lead to obstruction if we overexert and we do not recognize it, like prolonged first stage or prolonged second stage. By definition, failure of descent of the fetus in the birth canal for mechanical reasons, in spite of good uterine contractions, This was the definition given as early as 1982 by Philpott. Obstruction here often occurs at pelvic brim, but may occur even in the cavity and the outlet. Now, here we all know about the triple obstetric tragedy, but I would like to mention it here because this was the basis for labor monitoring. Princess Charlotte of England died after delivering a 9-pound stillbirth following 50 hours of labor. So both the mother died, the baby died. Here, there was obstructed labor. Then 3 months later, Sir Richard Crofts, who was the obstetrician, also committed suicide. The important thing is that this triple tragedy in 1870 changed obstetrics, the way obstetrics was being practiced at that time in England, and then it paved way for labor monitoring. Some more historical points. Obstetric labor has been studied for over 200 years. It was William Smiley who described the constriction ring. Danforth gave us the idea about Vandel's ring, and then pioneering works by Brownie, Shaw, and Nirula, Hudson, etc. They paved way for the learning about labor process and for prevention of obstructed labor, what we know today. The incidence, it is rarely seen in the developed countries, but 2 to 5% incidence has been reported in the developing countries. The bad part is 88% of maternal deaths are due to obstructed labor still in the developing countries. This figure could be an underestimation of the problem, and it is often classified under other complications like PPH or rupture uterus, while the basic fact that obstructed labor has occurred does lead to all these complications like PPH. Delayed complications like fistula make these women outcasts in community, and therefore it is all the more important to manage this effectively. Obstructed labor again accounts for 3 to 5% of emergency admissions in our large hospitals, mostly seen in unbooked cases admitted as emergency in late labor. And this reflects lack of proper perinatal care, antenatal, as well as intranatal and transport facilities. As you can see, the birth canal is dilated to such huge dimensions at the time of labor. And if there is any obstructing factor, then only obstructed labor develops. Some factor which leads to arrest of vaginal delivery when the fetus is not able to negotiate the pelvis due to mechanical obstruction or incoordinate uterine contractions in spite of good uterine contractions is obstructed labor. Then in short about the 3 Ps, the causes for obstructed labor. First, about falls in passage, bony contraction, any tumor in pelvis, any bony deformities, soft tissue obstruction like fibroid, constriction, and even sacculation of uterus or vaginal stenosis, septa, or tumors. At times, a big ovarian neoplasm can cause obstruction, as you can see in this picture. Falls in passage. First comes the cervix, the rigid cervix after conization or after amputation, which fails to dilate. Other factors like in passage, like pelvic kidney, tumors of bladder or rectum, even a vesical calculus may cause obstructed labor, which has been commonly reported. Then falls in passenger, large size baby, malpresentation, malposition, locked twins, fetal anomalies, which were not previously diagnosed because as ultrasound was not done. Even a small baby with absent Riker at times can cause obstruction. Falls in power, incoordinate uterine contraction, hypertonicity, or a tonically contracted uterus. Then there's a term obstruction in 3rd stage of labor. This occurs when the placenta is retained inside due to hourglass contracture because of injudicious use of oxytocins. Now let us come to the pathophysiology. The various conditions which are labeled as pathophysiology. First is premature rupture of membranes. When all liquor has been drained away, there is formation of a contraction ring at the neck of the baby, just above the shoulders. So this is an initial causative factor. There could be abnormalities in dilatation, like a thick lip of cervix, prolonged 1st stage or prolonged 2nd stage, which can then lead to obstruction. Then the major problem after obstruction is the danger of uterine rupture. The fetus is forced into the lower segment by contractions. There is excessive pressure on placenta and umbilical cord, fetal distress and death. But besides that, the uterus, the upper segment becomes thick, it contracts around the body of the fetus. The lower segment gets overstretched, and this is what leads to uterine rupture. In all such cases, if they remain so for a prolonged time, there's excessive pressure on the lower segment, decreased circulation and oxygenation, necrosis, which is seen after a few days in the form of a fistula. The morbid anatomical changes, the bladder, there is formation of a pathological retraction ring, which is known as the Bandel's ring. The bladder becomes overdistended, it becomes an abdominal organ. Then it may get traumatized, and there would be blood-stained urine and genitourinary fistula. As you can see in normal labor, this is the ratio between the upper and lower segment. But you see here in late obstruction, the lower segment becomes bigger, it is thinned out, and the upper segment is smaller. Now, I would not go into the details, but two types of rings are there. The Bandel's ring, which we commonly call as the retraction ring. Otherwise, there is a constriction ring also, which is because of localized incoordinate uterine contraction. This may not lead to rupture, but the retraction ring does lead to rupture uterus. So this is how you can differentiate a Bandel's ring easily, in which you see that there are two bumps, and in middle the Bandel's ring is there. Here also, in normal labor, the lower segment is thick, while in obstructed labor, it becomes at times bigger than the upper segment, and it is so thin that it may rupture. Clinical features, in most cases, as I've already said, labor gets prolonged. In a grand multiparous woman, labor may be quick, and there could be malpresentation, transverse lie. In these cases, obstructed labor occurs rapidly. The general condition of the woman, there is maternal exhaustion, dehydration, ketoacidosis, fever. She would have pain, shock, weak, rapid pulse, confusion, unconsciousness, and a decreased urine output. On examination, on inspection itself, at times a Bandel's ring would be visible. The lower part would be a full bladder. On palpation, you would feel incoordinate dysfunctional uterine contractions. At times, the widest diameter of the fetal head would be above the pelvic brim. Colicky pain and persistent suprapubic tenderness would be there. There would be a tender uterus in those cases in which there is impending rupture. And you would feel that there would be a large-sized baby because of which obstruction had occurred. Fetal distress is there, and at times an IUD may be there and you would not hear the fetal heart sounds. Now, the typical findings on vaginal examination, initially, we always need to catheterize the bladder, which could be difficult. The Follies may not go in. In such cases, you would need to push the head up and then put in a Foley's catheter, in which you would find concentrated or hematuric urine. The edema would be, there would be edema of the vulva, edema of the cervix, hot dry vagina. Peculiar finding is an uneffaced and loose hanging cervix at times. Occasionally, there could be an incompletely dilated or even a rigid cervix. Foul smelling meconium would be there, like having drained away. A varying degree of caput would be seen at times, even up to vulva. Head at times would be at zero station, and most of it would be caput. The typical finding of bleeding PV and a loosely hanging cervix is of rupture uterus. In these such cases, cause of obstruction could be anything. It could be a molded head, a shoulder, or even in all cases of abnormal presentation, a brow or a compound presentation. So typically, the woman would have an exhausted toxic look. There would be dehydration, tachycardia, fever, tonically contracted uterus, overstretched lower segment Bandel's ring. signs of threatened rupture, no liquor, large caput, and at times FHS not localized. So those were the typical findings. But before such severe phase goes on, you should suspect obstructed labor when the cervix does not dilate in spite of good uterine contractions. Molding and caput increase, but the baby's head does not descend. Patient becomes anxious or restless, or develops hypertonic contractions with poor relaxation in between. Other signs to look for are a stretched lower uterine segment, bloody urine, unexpected, easily dislodgement of head, followed by a gush of bleeding, cervix not well applied to the head. If you find a Bandel's ring, that is a definite diagnosis made. Now for management, 6 steps. First, identify and anticipate the possibility of obstructed labor. Decide the aim of management. Select the best management. Decide your priorities. Evaluate the outcome and provide further management if necessary. General management, as she has dehydration and ketoacidosis. Maintain a normal plasma volume and prevent dehydration ketoacidosis by starting in an 18 gauge IV line and giving ringer lactate or normal saline 1 liter every 20 minutes till her pulse falls and her BP rises to 100. At times, by giving rapid fluid, she may develop edema. So reduce the amount of fluid to 1 liter every 6 hours along with diuretic like furosemide. Immediately, we need to send some investigations urgently like blood grouping, cross-matching, CBC, urea electrolytes. And if an ultrasound is available, an ultrasound to localize fetal heart sound and confirm the presentation. So if sonography is easily available on your labor room. We need to give antibiotics, ampicillin, gentamicin. Higher generation, 3rd generation cephalosporins can be given. Blood transfusion may be needed, but if not needed, has to be kept arranged. Vaginal and blood culture sensitivity is to be sent. All such cases, precautions are do not use oxytocin drip if you feel any sign of obstruction. Do not try internal version. Never try to do an operative vaginal delivery. If you feel that the uterus is already ruptured, do a laparotomy. Never try to remove a fibroid at cesarean section. Always do it pre-planned. In most cases, obstructed labor can be prevented. And so we should talk about the preventive aspect as well. Good nutrition in childhood so that mothers reach their determined height and their pelvis is genetically determined. Promotion of appropriate and accessible antenatal care. And these providers should be trained in history and physical examination. Use of partograph in labor ward in all women in labor, and development of appropriate and timely referral systems. These are the ways by which we can prevent obstructed labor. Now, not going into much details, but prolonged or neglected obstructed labor with an intact uterus, there are 2 conditions, either the fetus is alive or the fetus is dead. If the fetus is alive, in all such cases, our aim is to deliver the fetus as fast as possible. She may be fully dilated and you may feel that you can apply a vacuum or forceps, but try it only if you're well versed with it and you're skilled in it. Otherwise, go for a cesarean section. Some cases you can do a symphysiotomy, that too, if you are skilled with it, because within minutes in such cases, you can deliver the baby. If the fetus is dead, some destructive operations are being considered, but that too, depending on the skill of the operator, you can try them. In all such cases, we do need correction of fluid and electrolyte imbalance immediately, and we need to be prepared for postpartum hemorrhage. Now, in some cases, again, there may be a ruptured uterus. You've done a laparotomy, you've opened the uterus, you've delivered the baby, and then you find that there is a spot, maybe a posterior rupture or a fundal rupture. In those cases, again, you need to take a decision for whether you want to go for a hysterectomy or you want to do repair. But before carrying out any surgical procedure, the course of uterus has to be identified so that you can avoid ureteric injury, which is a major complication. And the integrity of bladder should always be carefully reviewed because bladder wall may be involved in lower segment uterine rupture. So these were the surgical options. When you find that there is rupture uterus, you could do a total hysterectomy, subtotal hysterectomy, laceration repair with tubal ligation, or laceration repair alone. These are a long list of destructive procedures which can be done. Again, performance of destructive fetal operation will depend on local facility and the operator's experience. So if you are experienced, then only try it. The aim of treatment is to deliver the mother by the safest possible route. In all such cases, mother remains the first priority. If the fetus is alive, you can go for vaginal delivery or you can do a cesarean section. If the fetus is dead, again, you can go for a destructive operation or a cesarean section. These are various difficulties which can be encountered in cesarean section and you need to be prepared for them. There could be problems in anesthesia, problems in opening the abdomen. If there is a definite obstruction, Vandel's ring is seen, always open it vertically. Trauma to bladder can occur, difficulty in opening peritoneum because the bladder is very high up. There may be lower segment hematoma and rupture. Lower segment incision should always be given as high as possible. Difficulty in extraction of fetus, suturing difficulty, and PPH. PPH here could be both atonic and traumatic, but you should always take a quick decision in the golden hours. If you encounter PPH, uterine artery ligation or internal iliac ligation, V-Lynch or Chow sutures, or a hysterectomy. Whatever decision you take should be appropriate and should be quick. You can take the opinion of a second obstetrician in these cases. Post-operatively, these women should be managed on critical care lines in an OBS ICU. Abdominal drain should be left if needed, an indwelling catheter for 7 to 10 days, higher antibiotics and electrolyte management, and thromboprophylaxis. This is an important point which I would like to stress. You've saved the mother from all complications, and ultimately she develops pulmonary embolism and dies. So always think whether you need to give thromboprophylaxis, which is at times essential. Again, prevention by appropriate history taking, appropriate examination, and the progress of labor should always be charted on a partogram. As you can see in this picture, when your charting has gone to the right side, beyond the action line, it means some action has to be taken. Here, the baby weight was 4.6 kg. This baby would never have delivered. So if you plot a partogram, you have a wise decision taken. In some conditions like floating head, pendulous abdomen, occipito-posterior position, presence of prom, premature bearing down, drained liquor, repeated full bladder you're encountering, and fetal distress. In all these conditions, always plot a partograph in active labor, which would help you in taking an early decision and which would prevent this woman into going into obstructed labor. In all such cases, if you are at a periphery and dealing with such situations, early referral should be the aim. Lastly, the various complications and sequelae. Immediate complications, rupture uterus, genital tract trauma, PPH shock, and at times death. Delayed complications, febrile infection, endometritis, septicemia, fistula, subinvolution of uterus, thrombophlebitis, delayed wound healing, even obstetric palsies, psychosis, future obstetric complications, persistent anemia, and Sheehan syndrome. Fetal complications, asphyxia, sepsis, death, intracranial hemorrhage, trauma, and if everything has come out to be normal, there could be late neurological sequelae due to asphyxia. So my take-home message for all of us is proper management of normal labor is essential to prevent obstructed labor. Continuous and thorough assessments of the women and fetus contributes to limit negative outcomes by providing an opportunity for timely and appropriate treatment. So Continuous.
चला तो है ही, इसका वो नहीं है तो.
If obstructed labor is identified, prompt treatment is required to save the life of the woman. It is not always possible to save the life.
आप क्या करना?
Thank you. And I'm open to questions. If you have any questions, I would be happy to answer them. I have my presentation on YouTube. So if you would like to see it again, you can go to my YouTube channel. Thank you.
A very good evening to each and everyone, all my seniors and friends. I bring the greetings from Ratlam Obstetric and Gynec Society. And thank you very much for giving me this opportunity of being here on this webinar. First of all, I'd like to thank Dr. Anupama Dave ma'am for giving us this beautiful presentation. Very self-explanatory. No questions are asked in the chat box after your lecture, because your lecture, we have always been listening to your lectures and they're always very thoroughly equipped with all the knowledge that is required for that particular topic. We all knew about 3 Ps. It was very nice of you to get a more P, like a psychological factor in that P, and also about the pathophysiology, how obstructed labor is managed, and what are the reasons for getting a person into obstructed labor is the late referral. So thank you very much.
Thank you, ma'am, for excellent presentation. Covered all aspects beautifully. Thank you so much, ma'am.
Thank you.
At the end, from Ratlam Obstetric and Gynec Society, I would like to give a best wishes for the upcoming elections, and we are all with all the MP members.
Thank you so much. Thank you so much.
All the best.
Thank you, Dr. Jagrati. Thank you so much. It's nice to see everyone from MP and Dr. Sneha. It was wonderful webinar as under your guidance. And you are a true academician, and we all MP people are with you, Sneha.
MP is Gazab. MP
गजब है.
Move mountains. अब MP की बारी तो है ही, अब तो आ गए अपन. सेंट्रल स्नेहा तो हमेशा से अपनी है.
Thank you, my dear.
MP
Thank
वालों
you
को
for all of
किसी भी
your
तरह
love
all
and
societies
affection.
back up.
Thank you so much. Thank you, all the presidents and secretaries of AMPOX. I'm really privileged to have all of you here, and I'm thanking you for your not only presence but your wonderful, very useful inputs. Thank you so much.
Thank you. Now, shall we move on to our third session, Dr. Sneha, panel? All panelists are here. I can see Dipti, I can see Jyoti, I can see Shruti. And so you are going to have really interactive panel also. And Aditi is a newcomer. Is she there? Yes, Aditi. I think Shabana will not be able to join Dr. Sneha. She conveyed. Yes. So I have to introduce you as a moderator, but I think nobody
it's okay.
needs
You have
any
already
introduction on Dr. Sneha.
Yeah, thank you so much.
So I would like you to introduce one lines for our panelists.
Yes. So that's a privilege, my dear friends. I welcome all of you once again. Dr. Jyoti Karande, who is the Secretary of Indore Obstetrics Society currently, and she is the member of Foxy Quiz Committee. Of course, she's the examiner of Part 3 MRCOG, and she has many posts hold in the past as well. So welcome, Dr. Jyoti. Dr. Shabana, as she said, I think she's not well. So she could not join us. So we are missing you, Shabana, and Dipti Gupta, who is the Secretary of Jabalpur Obstetrics Society, Associate Professor of Department of Obstetrics and Gynecology, and of course, she's also the Foxy Quiz Committee member. Welcome, Dr. Dipti. We can go ahead. Dr. Aditi Rathore is a consultant of Rathore Nursing Home, Jaora, and she's got appellations and awards of Work Area Member Organizing Committee of AMOGS 2018, And of course, the PSMA award in 2019 she's got. So her special interest is in the field of obstetrics and fetal medicine. Welcome, Dr. Aditi. Next, Dr. Shruti, a very dear friend, a young, enthusiastic, bubbly personality. And yes, I'm very privileged to have you, Shruti. I know how wonderfully you work, whatever you decide. So apart from your formal CV as founder secretary of the Narmadapuram Obsgynae Society and president of Narmadapuram Society. Welcome, Dr. Shruti. You can stop sharing. Yeah. So a very good evening, all of you. First of all, I would just convey my apologies for not communicating with you properly. The reason, I think all of you know, I just lost my mother-in-law a few days back, and I was busy with the rituals. But you know, friends, this is a responsibility and we have to move on. This program was planned earlier, and that's the reason. We do have two cases which are based on hypertensive disorders. So I have shared with you the panel discussion. So now I take this opportunity to share the screen and just start with the panel discussion without much ado. So I hope you can see my slides. Yes.
Yes, ma'am.
Yes, and they are full screen.
No, ma'am. It's not on slide 2 yet.
Yeah, you can see now they are full screen.
Yes, ma'am.
Yeah. So, friends, we have been always talking about maternal mortality rates and ratios, and we are always talking that from 500 we have come to less than 100 now, and we take the pride and privilege to serve the women. But this is not just statistics, not numbers and ratios, friends. These are women. They have their faces, and we see these faces in the faces of their distress, despair, and agony. So these are the faces which continue to haunt our dreams. That is how it is expressed by the past FIGO president, Dr. Mohammed Patala. And I'm sure all of you share the same sentiments. Looking back over the clinical times, one tends to forget or take it for granted the one's success, but it is the failure that stands out like a keloid, never to be forgotten by the person who suffers it, and hopefully warning for the others. Friends, we're talking about near miss. So this terminology is actually borrowed from the airlines. It tells you the gravity of the situation and the urgency of intervention it demands. So it is defined as the critically ill pregnant woman or recently delivered woman who have otherwise died had it not been the luck and the good care on her side. So the analysis of such near miss cases not only tells you, they're not only the learning lessons for that particular person, but to the obstetrician as a whole society. And this magnitude of this severe acute maternal morbidity is very, very high. And if you try and analyze it, it will be a very good lesson for all of us to learn. So why this concern is rising nowadays, I'm sure you all are facing this same, we are sailing in the same boat. The demography has been changing. The age of the childbearing is becoming quite delayed, maybe 30s and even late 30s and 35s. The age where even the otherwise you have the associated comorbidities, usually the medical comorbidities, even the surgical morbidities have been on the rise. And that is why having high index of suspicion, prediction, prevention, and preparedness is the key to success. So friends, all of us are still the students, and life is the best teacher. So never stop learning, because life never stops you teaching. So every case is a different experience. So with this, we start with our first case. We have this second gravida, first previous cesarean section. The baby is only 1.5 years old. She comes to you with 7 days over to you. You do her urine pregnancy test. It is positive. Dr. Jyoti Karande,
Yes.
Jyoti Madam, I would like you to have.
Madam Jyoti.
Yeah. So you have this patient previous seizure with one live issue, 7 days overdue, urine pregnancy test is positive. The obstetrician prescribed, the tablets and called her for after 7 days. But so she was having only spotting and started feeling giddiness. But she thought maybe the doctor has called after 1 week. Suddenly on 6th day, the relatives got her at around 11 p.m. in a collapse state. What do you think, what is the diagnosis of this patient? What would have gone wrong? And how will you manage this patient?
So were her previous cycles regular?
Yes.
Yes. So only 7 days
Urine
overdue.
pregnancy test is positive and you are
Yes.
given her
Only 7 days. And was an ultrasound performed before giving a pill?
That is what you have to talk about. That
Yes. So
your diagnosis and how will you go
so
ahead?
It can be two possibilities. If the
Yeah.
ultrasound was not performed, it could be an ectopic pregnancy which has ruptured,
Okay.
or it could be a advanced pregnancy, and maybe she has had a rupture of the uterus because it was not supervised. So we need a more detail. What was the ultrasound report? What was the previous history? What was medical?
Yes. So your first take-home message from this case is the ultrasound should be performed before prescribing the empty pills or the medical pills for medical termination of pregnancy. So that is one, because you know the exact duration of pregnancy, because there is a restriction that beyond 60 days, you should not be prescribing this, and of course to rule out the ectopic pregnancy. Now the patient is in a collapse state, pulse rate is 132, blood pressure is only 70 millimeter of mercury, pallor is plus. So your differential, you have said either it is a rupture uterus, you meant to say, or it can be a severe bleeding or ectopic pregnancy. Now, when you do her ultrasound, you find that, there's an adnexal mass and there's a free fluid in the pouch of Douglas. Her hemoglobin bedside done, it was 7 gram%. Now, do you want to revise your diagnosis, come to the definitive diagnosis?
So now, based on ultrasound and clinical features, the diagnosis is ectopic pregnancy, which probably has ruptured and caused her hemodynamic instability. And now this is a medical emergency and it has to be managed immediately.
Okay. So how will you manage this, madam?
So since she is hemodynamically unstable, the airway, breathing, circulation, resuscitation, immediately call for an anesthetist, call for your team immediately. You will need also you need help of a hematologist. You may require we will require blood transfusion here, and inform the patient and the family that since she is hemodynamically unstable and she will require an urgent surgery for correction of this ruptured ectopic.
Correct. So you have to talk to the relatives and take an informed consent that she needs to be operated urgently and she will definitely need the blood and blood products. So you have to take the consent in that manner. It should be an informed consent with a consent for blood transfusion right at the beginning, and also maybe possibility of the surgery which is getting, there can be some modifications that you have to tell them that we are not sure what the diagnosis is. We have to do a laparotomy and then decide what we have to go for. So that is how. Now, what is the procedure of choice for this patient? This is just a question, just a by-the-by question, whether you will go for laparotomy or laparoscopy, and what will be the procedure, whether it is be partial salpingectomy or it will be a conservative surgery.
So it depends. If she is hemodynamically very unstable, then it will be an urgent laparotomy, because laparoscopy again has anesthetic complications, CO2 insufflation, and it may be not so rapid. So if clinical condition is deteriorating, I would prefer a laparotomy. And if it's a ruptured ectopic, then salpingectomy. If it is the tube can be salvaged, then maybe just removal of the ectopic. But most probably in this condition, looking to her general condition, it will be a salpingectomy. Look at the other tube also, whether it is good or not. That may also make a change.
May not make any necessary changes.
Yeah.
If it's a rupture,
and already she has,
you have to go for
yes.
Yes.
And she has one child.
Lessons, madam. What are the learning lessons, Dr. Jyoti, you would like to tell all our attendees for this case especially?
First, that before giving MTP pills, we have to be very sure that the pregnancy is intrauterine. At least on 7 days overdue, you may not be sure on PV examination. In that situation, you may have to do a ultrasound to make sure that it's an intrauterine gestational phase.
Is it mandatory?
It is not mandatory. It is not mandatory, but it is advisable.
Mandatory, but it is advisable.
Advisable, yes. Especially when it's a previous scar and then you suspect cervix may have not dilated in previous pregnancy. This time also it didn't dilate. Even if it is uterine, there may be problem. And of course, if it is ectopic, there is always a problem. Again, if we are doing it, we have to tell the patient that though we have called her after 7 days, anytime if she has any problem, she should contact. We should give her emergency contact number, where to contact, how to contact, where to come in case she's not feeling well. Because in this situation, she has almost gone in the stage of shock before coming to hospital, thinking that she has to go only after 7 days. So all the possibilities should be discussed with the patient before giving her.
Yes. So for this patient who has received MT pills, she was getting only spotting and the gidding, which is very classical of distension of the tube, the vasovagal episodes, which are so classic for ectopic pregnancy. So she was having the history, and we could have avoided this panic situation and the situation of shock. Thank you so much, Dr. Jyoti.
Thank you, ma'am.
Very wonderful discussion of this case. Now we go ahead with the second case now. And this is a case, 36-year-old woman. She conceived after IUI. Her husband is working in Dubai. She lives in a village, but because she has conceived with this IUI, she came regularly for the checkup up to 34 weeks, and she came up to 24 weeks only, and then she disappeared. At 34 weeks, she started getting mild pain in abdomen and little edema. So locally, her blood pressure was measured. That was 176/116. The fetal growth was apparently normal, and she was having proteinuria. So LFT, RFTs, and hematocrit were normal. So tablet nifedipine was started for this blood pressure, this hypertension, and she was advised admission and counseled for the possibility of early delivery, which she refused to get admitted. So now this patient went into the secondary level hospital, where she was again examined. Her blood pressure was still 168/110, and then they started her on tablet labetalol, and then nifedipine Rita tablet was already there. Her blood pressure was in the range of 140 to 180 in spite of all this, and she has also received the magnesium sulfate and steroids. For the baby, she has received the steroids also. Cesarean section was done at the district hospital, 1.8 kg live baby, and maybe around say 30 hours after the cesarean section, she started developing sudden severe cough, breathlessness, and restlessness. And when we saw her blood pressure was 220/118, the pulse rate was very high, and the oxygen saturation was only 70%. Chest, there was wheeze and no clear breath sound. So I think we don't have Dr. Shabana, so Dr. Shruti can take up this case. What is the diagnosis, and how this case was I would say, what is the diagnosis and how will you manage first?
Then because of the duration after the delivery that this has happened, we would and we should suspect an amniotic fluid embolism as well. Because of her clinical condition and her complaints. And so we'll first have to stabilize her, oxygenate her, and then manage her hypertensive crisis, which she is in. And then she's having pulmonary edema. If she's having a gross pulmonary edema, then yes, we will have to manage that. And intensivists should also be there. Multidisciplinary approach has to be taken into consideration. And then after stabilizing the patient, we can go ahead.
Yeah. So here, basically, this patient has landed up into pulmonary edema. Yes. Though the possibility of pulmonary embolism cannot be ruled out, you very rightly pointed out by you. So you have a similar picture. Of course, the echocardiography and X-ray or CT chest will, differentiate between the two. So here, Basically she's into pulmonary edema. That is what we have to take into consideration. So first and foremost, apart from the ABCD your way of management, you have to call for help and get all your staff, get all your colleagues, get the intensivist, also get your lab and also the blood bank, because if she goes into DIC, then also you will require the blood and blood products. So everything has to be, kept ready, and the things have to be discussed with the patient as well as with the relatives, that your team has to do, but you have to be there and managing simultaneously everything. So you see whether she's breathing properly. If she's not breathing, then you have to put her on mechanical ventilation, give her oxygenation, and of course then you manage whether she's circulation is good and all those things. Then of course, when you have this, you have to, when you put in an IV line, you have to give Lasix, large quantity. It's not 10 ml, 20, but 40 and 80 milligram of Lasix you have to go, furosemide, that you have to give. And then of course the intensivist will manage the rest. But then what went wrong as an obstetrician, you find? Dr. Dipti, you can take up this question. What went wrong for this patient, and at what level rather?
Ma'am,
yeah.
This patient, since she was a severe preeclampsia to start with, and she underwent an operative delivery. So in such patients, strict monitoring, especially of input-output and thromboprophylaxis are two things which...
I would take you a little back. This patient was a very high-risk patient, right?
Yes, ma'am. Elderly who
36-year-old. Yeah,
Yes.
with
Yes.
infertility, with
infertility
CRT
treatment.
techniques, okay?
Yes.
So she becomes overall a very high-risk patient. So
Yes.
whether right from early pregnancy, you could have screened this lady for development of preeclampsia or HDP.
Yes, ma'am. So in
What
early
were they?
trimester, her screening should have been done. And if at all high risk, then she should have been put on tablet Ecosprin 150 milligram bedtime to prevent severe preeclampsia to a certain extent in the first place.
Yeah.
And then thorough counseling with regards to, all these complications likely to happen in the third trimester, so that she could have continued with her antenatal care.
Yes.
If she was there till 24 weeks with proper counseling, she could have continued in third trimester as well.
Perfect.
And that could have potentially prevented, all these complications from happening.
First and foremost, it's not that, the patient is coming, then only you manage. If she doesn't come, it's not your responsibility. That is not the way of management of any patient, I would say, any pregnant woman for that matter. So considering, 36 years old, infertility, conceived with IUI technique, all these risk factors, puts her into very high risk. So her maternal characteristics, they are in favor of, high risk. Now you put this patient, subject her for screening for HDP, right from her biophysical profile, biochemical predictors, markers. You can go for any marker you find high risk. You have to explain her then and then, even at 11 to 13 weeks, you can go for, the uterine artery percentility index. Before that, you can go for dual marker and also SFLT and, PIGF. So all these biochemical markers also can be done, and she should be warned. The relative should be informed that she is very high risk for development of this, and so that she should be put on aspirin, that is 75 or 150 milligram, whatever you are well versed with. The recommendation says that if she is less than 70 kg, aspirin 75 milligram, and if it is more than 70 kg, then 150 milligram. And she should be put on high dose vitamin D, calcium and vitamin D. So these are the two: low dose aspirin and high dose calcium and vitamin D. These are the proven predictors or proven protectors, I would say, for HDP. Now, when you are monitoring this patient, you have to see that even the subtle changes of blood pressure. That's the very reason I have posted a PPT on hypertension, that at what is the blood pressure where you should start antihypertensives? What is the blood pressure?
Ma'am, so there are, as per the recent ISHHP guidelines, there is something that is a severe hypertension and the mild hypertension. So the mild...
My question is very clear, Dr. Dipti.
Yes, ma'am.
At what blood pressure you will start antihypertensives?
Ma'am, if it is
if
it is persistently above 140 by 90 millimeters of mercury, then we have to initiate antihypertensives.
Yeah. So I want to give the message to all the audience that previously the NICE guidelines and even the SUG, they said, if it is more than 150 by 100 millimeter of mercury, then only you should start antihypertensive. But now World Justice Organization and even IHSS, it says, Justice says 140/90 is the cutoff where you should start antihypertensive. I'm sure majority of you must have seen the patient convulsing even on 140/90. A patient having, impaired liver function even at 140/90. So don't wait for. So IHSSP says that it should be 130/5 by 85. It has even come down further. So that is what the recommendations are. So for us to be on the safer side, if you have the increase in the systolic blood pressure by 30 millimeter of mercury and increase in the diastolic blood pressure by 15 millimeter. So if you have 110/70, that becomes 135, and if you have 70 that as diastolic, so even 85 becomes hypertensive by definition, and that is a cutoff where you have to start antihypertensive. So this patient could have been started on antihypertensives very early, and she could have been maintained, stabilized. That is one. Second, 2 points already. Screening we missed early recognition. And thirdly, when she presented to you with 176, 116, you cannot just tell her that take this tablet and
go home.
It is very severe. Now you tell me what antihypertensive should have been given at this point of time, 176/116.
Ma'am, at this point, two things need to be assessed.
Yeah.
One, antihypertensives have to be initiated, and at this value, perhaps nifedipine would be a better drug.
Yeah, I give you two choices. Yeah, here intravenous labetalol. See, wherever you have severe hypertension, you have many choices for intravenous antihypertensives, but the best and the first one is intravenous labetalol, and definitely second one, as you said, it is nifedipine, but not tablet, not retard tablet. It's a orange color capsule, which is a oral capsule, right? So oral capsule gives very, very good results. It brings down the blood pressure quite effectively. The onset of action is within 5 to 10 minutes. The peak action is within half an hour, and the duration is for 6 hours. So you could have easily, effectively achieved, the normotensive level. Okay, so that was one. Now this patient refused admission. Does it mean that you have to send them, neglect them? Should take everything in writing, so that when you convince the patient, when you tell them that even she may converse, she may become serious. So if you tell them, I'm sure the relatives get convinced. So it's not that if the patient doesn't understand, we have to counsel them, advise them to get admitted wherever she wants, but she should get admitted. Okay, so that is one. When you do the cesarean section, what precautions should have been taken, because she's already hypertensive. What do you feel that, something must have gone wrong here also, Dr. Dipti?
Ma'am, these patients, as we know, their intravascular compartment is compromised. One, that added with the thrombogenic state of pregnancy, they are more prone for thromboembolic complications.
Okay.
In these patients, post-operative care also becomes equally important.
Correct.
And a strict
But I take you one step earlier. During cesarean section, what drugs you have to avoid? The oxytocin? Which oxytocin?
Ma'am, in oxytocin can be safely administered.
Yes. Which oxytocin should be avoided? That's what I'm asking.
Methyl ergometrin.
Yes.
That
is a very, very clear-cut message to be given to all the obstetricians that when the patient has hypertension, then ergometrin, methyl ergometrin, methergine, whatever you call
contraindicated.
It is contraindicated, and this is a case where you have to prefer carbetocin as a prophylaxis, and maybe if you can maintain it on oxytocin also later on. So That is what you have to take care of. So all these, mistakes at every step of all of them have, landed up this patient into pulmonary edema. Now you have managed this patient. The anesthetist was called, everything was given, mainly the injectable labetalol Lasix. Anesthetist was called, mask oxygen was started, and after 10 minutes, the pulse was not recordable. Oxygen saturation was 55%. Even on AMBO assisted, the patient was being shifted to ICU because she was in the ward. See, one more mistake. She was in the ward. This patient went into cardiac arrest. Now what next? Whether you want to take up, we can go ahead with the next panel.
Ma'am,
yes.
Ma'am, again, counseling of all the patients and patients' attendants is extremely important. And while counseling, we have to be empathetic. We have to explain the entire situation right from the beginning, like we have discussed.
Yeah.
And we have to allow them to grieve. And of course, we have to document everything in a timely, proper, sequential, chronological manner.
Correct.
And if required, we must always offer the option of post-mortem procedure.
She's already delivered. She's already delivered. What we are talking is post-mortem procedure, you said.
Yes, ma'am. Post-mortem, as in after the patient's demise.
Okay. That we're not talking about demise. We're talking about near miss. We don't want our patient to die, my dear. So she received cardiopulmonary resuscitation. She received 100% oxygenation. Then she was revived by intensivist anesthetist. Her blood pressure came up to 88. Oxygen saturation came to 90%. And after 1 hour, the patient was on spontaneous respiration with blood pressure of this. But the confusion prevailed here. What went wrong and whether this could have been prevented. So this is the sequence of event we have already discussed, that the pulmonary edema is actually accumulation of the fluid in the pulmonary interstitial and alveolar spaces, and hypoxemia increases. There is increased work of breathing, and this happens because the lung compliance becomes less. It doesn't become, it cannot expand to its fullest capacity. So here, these are the very reasons, during pregnancy, I'm just taking them forward, that this is how they lead to pulmonary edema. And if they have pulmonary edema, you have to check the airway, check breathing, circulation, and give the necessary drugs like dopamine, dobutamine, assess her arterial blood gases, do her chest X-ray and ECG, and of course the routine blood count, complete blood count, cardiac enzymes, coagulation studies to know what exactly if the patient is having rhonchi, to improve the lung compliance, you have to give her nebulizer, give steroids, whether such kinds of reactions, especially they manifest like this. So she may require assisted ventilation. And of course, such patients who is already in pulmonary edema, she requires a invasive monitoring, that is with central venous pressure monitoring. So thank you, Dr. Dipti. Very well discussed. Yeah. So do we have Dr. Aditi here? Do
we have to tell our staff to take care of the fluid? Otherwise, like normal cesarean, they will put.
That is why I have said that we need to go for invasive monitoring for this patient, that is central venous pressure. You have to be very cautious about the fluid. And Dr. Dipti has already said that she has restricted intravascular compartment. Okay, so this is the last case we will discuss here. Do we have Dr. Aditi here? Yes, Doctor.
Yes, ma'am, I'm here only.
Okay.
But actually, I just had a patient right now. So therefore,
this is the last case we will discuss with you. We have this 20-year-old primary gravida, 9 months, Amina. She came to you at 11 p.m. and she gives you history of admission at a nearby nursing home. She has very strong labor pains since 3 to 4 hours prior to admission. Okay. So at 3 p.m. she got admitted to some individual small nursing home where she came with labor pains 4 hours prior. And from 3 p.m. now it's 11 p.m. Okay. So almost 12 hours of labor pain she had. So there was failure to progress. So she was taken up for, she was posted for cesarean section. Now, when the sister catheterized the bladder, there is absolutely no urine output. Now, retrospectively, they thought now since admission, she has not passed urine. So it's a case of, I would say anuria. So this patient was shifted to the tertiary care center. So where the pulse rate was 110, blood pressure was 110/70, uterine contractions were plus, severe in intensity, fetal heart was 100/120, cervix was almost 7 centimeter dilated. So what is the uterus was, contractility was plus, there was no relaxation in between. So what is your diagnosis, Aditi?
If the uterus, there was no relaxation of the uterus, she was in hypertonic contraction, but the investigations are pointing towards DIC.
Yes. So the investigations were, PT-INR, it was 2, FTT was prolonged, the platelets were 1 lakh, near about. FTP was fibrinogen degradation products were present, and fibrinogen was very low, that is 150. So what is your diagnosis? And what was all the problems? How will you tackle it?
So, ma'am, as your slide has already mentioned, the diagnosis abruptio placentae.
Yeah,
so I could see
you
that.
discuss how will you manage?
So, ma'am, now that she is a case of abruptio placentae, ideally that she should be delivered as soon as possible. And now that the patient is in DIC, so she should be taken up in a higher center as she's already reached.
She is in the tertiary care center, and you are the managing doctor.
And then we have to involve an intensive assist and a high critical care. Everybody has to be involved.
Everybody is here now. Whether you will go for the cesarean section first or you will go for the blood and blood products.
Ma'am, I will arrange for arranging the blood. First of all, I will give her FFP. My first thing will be I'll give her FFP.
And you will wait till then, and the baby dies. Baby is in distress. Baby is in distress.
Yes, ma'am. She is 7 centimeter dilated right now.
Yeah.
So, ma'am,
but it's a case of prolonged non-progressive labor. Okay.
Yeah.
So
ma'am,
we have to go for cesarean section. Shruti, you want to add something?
Yes, we should take her for cesarean. Other things can follow simultaneously.
Yes.
We have to take out the baby.
Yeah. So both of you are right. In fact, she said, yes, you will arrange, but you will arrange, you will arrange for blood and blood products. You will arrange for anesthetics, OT, this, that, but everything has to be simultaneously. Okay.
Yes,
that is what the message from this case actually.
Yes.
Otherwise, all of you know everything. This is quite a long case. In fact, I would just ask you, what are all the problems here? She's having, obstetric hemorrhage, that is abruptio. She's having hypo. This blood pressure 110/70 may not be her original blood pressure.
Yes.
Okay, she may be having very severe hypertension, which has led to abruptio placentae. And now she's got obstructed labor, she's got fetal distress, she's got coagulopathy also. So you have to manage everything simultaneously, and of course go for cesarean section with all this blood and blood component. What precaution you will take, Shruti, for this patient to when you operate? As per, whether you would operate, whether you would,
if she's otherwise stable, then we go. If she's not that stable, we should go for general anesthesia. And so that the time lapse is less and we can take out the baby faster.
Yes, but by the time your blood and blood products are being arranged, I think that will take some time. So in fact, you can whether you have to see whether she.
No, we have to see the platelets actually.
Yeah. That
if the platelets are less than 50,
1 lakh. Yes.
Yeah,
see,
it's that and the
platelets should be more than 75,000. If they are okay, then we can go ahead.
Yeah, so it is 1 lakh. So rest of the things, all of you know, this was the critical decision only here, so that you know what is the level of platelets required for operative procedure. Minimum 50,000 should be there, and for a normal vaginal delivery, it should be, I think, 20,000 should suffice. If the patient is asymptomatic, not bleeding, you need not worry, but you be cautious and you go for arrangement of the blood and blood products. That is what the message is, my dear. I have lots of interesting cases, but I have to go for another program also I have, where I have to deliver my talk. and maybe some other time we can have diabetic ketoacidosis and all this. But I thank all the societies of Madhya Pradesh, and I humbly request all of you with my folded hands that because I'm working for Foxy since long, and I'm a private practitioner like majority of you, serving the community for the last 3 decades, that is 30 years, I appeal to all of you to support my candidature and vote for me as Foxy Vice President from West Zone. So I just expect that all of you vote for me, and I see you and meet you as Vice President Foxy in future, and wish to involve you as I have involved Dr. Shruti also in some of the activities. I would like to work in close association with all of you. Thank you so much.
Thank you, ma'am.
Sneha.
Best
Thanks
wishes.
a lot. All the best and congratulations in advance.
Thank you, my dear. Thank you so much. Thank you. And with all of your
Best wishes, ma'am.
I just take your leave. Thank you so much. Thanks, Dr. Dipti.
Thank you, ma'am, and best of luck.
Thank you, dear. Thank you so much, Dr. Aditi.
Thank you, ma'am.
Thank you so much.